Okay, so I think we will start on time. Welcome everybody to this APSC Cloud Forum of Cardiovascular Disease Series. Today's episode is continued progress in current medical and interventional strategy in the management of STE and the non-STE acute coronary syndrome with or without complications. The date today is May 29th, and we are covering a wide region of the APSC area. So the session theme is that we all understand that best medical and interventional strategy in the management of STE and non-STE acute coronary syndrome, chronic coronary syndrome, and the infarction with cardiogenic shock have been evolving critically into a new horizon. Early full revascularization in non-STEMI and STEMI with physiological and imaging risk verification is earning steady evidence in emergency coronary intervention. For most critical AMI with cardiogenic shock, mechanical circulatory support via Impeller has finally demonstrated its superiority in hard endpoints of long-term survival and MACE in the danger shock trial. Medically, the combination of timely dual antiplatelet or new P2Y12 receptor antagonist alone, as well as GDMT for myocardial dysfunction, are contributing to better post-interventional survival. For chronic coronary syndrome, novel concept of preventive PCI for non-obstructive high-risk coronary plaques has also demonstrated for the first time its clinical evidence in the PREVENT trial. So in today's webinar, we will discuss in depth the continuously changing therapeutical concept in the therapy of ACS, CCS, and MI with cardiac shock complication. So I myself is Dr. Xianli Gao. I'm currently the chair of the Cardiovascular Center in National Taiwan University Hospital. I'm also the chair of the Cardiology Division, Department of Internal Medicine, National Taiwan University Hospital. And currently, I'm holding the position of the president of Taiwan Society of Cardiovascular Intervention. So I'm very honored today to co-host with Professor Minami from Japan.
Thank you for the introduction. I'm Yoshiyasu Minami from Kitasato University Hospital in Japan. Today, I will be the co-chair and also present one topic. So please look at this disclaimer and the housekeeping. The content of this webinar, could you please go back? Thank you very much. So this content is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. And the views and opinions expressed in the webinar are those of the faculty members and don't necessarily represent those of the APSC. And the live streaming content of this webinar will be made available by APSC Cloud, APSC Facebook, and YouTube page. So let's get started. So I'm very happy to introduce the first speaker from Mongolia, Dr. Mijishuren Yambert. His topic is the role of the beta blocker, ACEI, ARB, ANI, and SGLT2 inhibitor in STEMI and non-STEMI, built after reduced MY and impact MY. So are you ready to present?
Hello. Yeah, I'm ready.
Okay, thank you. Please go ahead.
Okay. Can you see my presentation?
Sure, perfect.
Okay, perfect. Thank you for a nice introduction, and thank you all of you for take time to attend this forum. So today's topic is as introduced, and I have nothing to disclose. And today's presentation is covered to the following topics: current guidelines for long-term management after acute MI, and interesting detail this year, 2024. So this presentation mainly based on the ESC guidelines of the management of acute coronary syndrome, and also looking for the AHA STEMI guidelines and non-STEMI acute coronary syndrome guidelines. After the acute coronary syndrome, our main goal is to maintain proper long-term management to increase quality of life and decrease morbidity and mortality. For this purpose, we take the comprehensive management for the patients, like lifestyle management and patient education and cardiac rehabilitation. And also, one of the integral part of this management is pharmacological treatment. Pharmacological treatment we use various type of the treatments like antithrombotic therapy, lipid therapy, etc. But today's my topic is mainly focused on the beta blockers and RAS inhibitors and SGLT2 inhibitors. In current guideline, beta blockers have class 1A recommendation level in patients with reduced ejection fraction, but 2A class 2A recommendation level for all other patients regarding to the left ventricular ejection fraction. It's mainly associated with the previous data suggest the benefit of beta blockers are primarily regard to the patients with large infarct sites and left ventricular systolic dysfunction, and so the population with the left ventricular mid-range left ventricular ejection fraction and preserved ejection fraction, we have a lack of the proper and big randomized clinical trials and lack of the evidence. In terms of the RAS inhibitors, we use the RAS inhibitors with a class 1A recommendation level for patients with heart failure and diabetes, hypertension, or CKD patients. And we use all the other type of the RAS inhibitors. ACE inhibitor is first choice, and ARNI as a replacement for the ACE inhibitor. And patients who tolerate with ACE inhibitor neither ARNI, you can use the ARB. For medications for the diabetes, we use depends on the patient's comorbidities like heart failure, CKD, and obesity, and their glycemic status. The recommendation level is 1A and 1B. In terms of the SGLT inhibitor, we have a big trial is the AMI, and AMI trial shows us the empagliflozin led to significant improvement in NT-proBNP level and the echocardiographic left ventricular function and the structural parameters. But this trial was not evaluate the clinical outcomes. So today's first interesting study is the REDUCE AMI study. Full name is randomized evaluation of the decreased usage of beta blockers after acute myocardial infarction. This study recently published in the New England Journal of Medicine in April 2024 in this year. Purpose of the study is to evaluate the impact of the oral beta blocker treatment in patients with acute myocardial infarction and preserved ejection fraction. This study is registry-based randomized clinical trial and international clinical trial. It contains the 25 centers of the 3 countries and randomized 5,000 patients, and median follow-up is the 3.5 years. Inclusion criteria of the study is age 18 years or older, and within the 7 days after the myocardial infarction, and coronary angiography performed during the hospitalization, and obstructive coronary artery disease is documented by the coronary angiography, like stenosis greater than 50%, and FFR is less than 0.8, such like, and the echocardiography is performed after MI showing, and they had the normal ejection fraction defined as EF greater than 50%. Exclusion criteria is contraindications for beta blockade and indication for other beta blocker use. So the study participants 1-to-1 ratio randomization, and one hand is beta blocker group, other hand is no beta blocker group, and in oral beta blocker group they use the metoprolol up to 100 milligram and bisoprolol up to 5 milligram once daily, and they follow the patients duration of 3.5 years. Primary endpoint is the composite death from the any cause or new myocardial infarction, and secondary endpoint is death from any cause or cardiovascular cause, and hospitalization for the atrial fibrillation and heart failure, and they are as a primary diagnosis, and myocardial infarction. So we show from this slide clinical general characteristics of the participants. So minority of patients were female, and the minority of patients had previous cardiovascular disease like myocardial infarction, previous PCI, and stroke, heart failure. And only 35% of patients had ST segment elevation myocardial infarction. And regarding coronary angiography, half of the patients had one vessel disease, and only 16% of patients had left main or three vessel disease. So in terms of the primary endpoint, composite of the death from any cause or new myocardial infarction as a primary endpoint. So we see from this picture, they had no significant difference between the two groups among the components of the primary endpoint, death from any cause or new myocardial infarction. So also there is no significant difference for both groups. Generally, this study is a negative study. So secondary endpoints we can see from this slide that all secondary endpoints had no significant difference, and hazard ratios crossing the 1. And safety endpoints are also no significant difference, like hospitalization for bradycardia, second or third degree AV block and hypotension, and asthma, hospitalization for asthma and COPD, etc. So we conclude for conclusion of this study is in patients with acute myocardial infarction and preserved left ventricular ejection fraction, long-term treatment with the beta blockade did not reduce risk of death from any cause or myocardial infarction, and no apparent effect on the secondary variables. So second interesting study is the impact MI trial. full name is the effect of the empagliflozin on heart failure outcomes after myocardial infarction. So this study also recently published in the New England Journal of Medicine in April in this year. So purpose of this trial is to evaluate impact of the SGLT inhibitors in patients with acute myocardial infarction and high-risk heart failure patients. This study is streamlined, multi-center randomized, placebo-controlled superiority trial. So it's included the 451 sites from the 22 countries, and they had randomized 6,500 patients, and follow-up duration is 17.9 months. Inclusion criteria is type 1 STEMI or non-STEMI, and within the 14 days after admission in hospital, and high risk of heart failure, defined as they has had signs, symptoms of the congestion requiring to treatment during index hospitalization, and newly developed left ventricular dysfunction. And at least one of the risk factors of the heart failure, the following risk factors, and exclusion criteria is the previously diagnosed heart failure and in medication of the SGLT inhibitor. So the patient randomized to the one-to-one ratio, two groups, EMPA group and placebo group. Empagliflozin group took the 10 milligram empagliflozin once daily and plus GDMT, and placebo group is with GDMT. So they follow up the patients, and primary endpoint is time to first event of the composite of hospitalization for heart failure or death from any cause. So secondary endpoint is the total number of hospitalization for heart failure, non-selective cardiovascular disease, and myocardial infarction plus death from any cause. So in general, the characteristic of the patients, vast majority of the patients had left ventricular ejection fraction less than 45% as reduced ejection fraction, and half of patients had the sign and symptoms of the congestion requiring the treatment, and vast majority of patients were men, and half of patients were 65 or older years and older, and vast majority of patients had STEMI, and only one out of the three patients had three-vessel disease, received from the graph. So in terms of the primary endpoint, composite of first hospitalization for heart failure and death from any cause. Primary endpoint is was occurred 8% in empagliflozin group and 9% in the placebo group. So there is no significant difference between the groups. But as components of the primary endpoint, in terms of the first hospitalization for heart failure occurred in 118 patients in empagliflozin group, in 153 patients in placebo group. Hazard ratio is 0.77, so it's a significant difference. Favor the use of empagliflozin. In terms of death from any cause, there is no significant difference. Secondary endpoint. All secondary endpoints had no significant difference between the groups, and the total non-elective all-cause hospitalization and all-cause mortality is significant, but it's one of the component of the primary endpoint. But one interesting thing is from the secondary endpoint is total hospitalization for heart failure occurred 148 events in empagliflozin group, or 207 events occurred in placebo group. There is a significant difference. P-value is less than 0.01, and hazard ratio is 0.67. We see from this. In conclusion, empagliflozin did not reduce the risk of composite primary endpoint, like composite of the first hospitalization for heart failure and death from any cause after the acute myocardial infarction. And but empagliflozin demonstrated the 23 and 33% relative risk reduction in patients with for reduction for first hospitalization of heart failure and total hospitalization for heart failure. Yeah. So from the study, just we might get a possible clinical impact of impact in terms of the reduced MI trial. Reduced MI trial supports the move towards the de-adaptation and the prescription of the beta blocker utilization in low risk post-acute MI patients with preserved ejection fraction without another indication for beta blocker therapy, as like arrhythmias. And in terms of the impact MI trial, there is what remains unclear is timing of SGLT inhibitor initiation and best patient groups to consider the SGLT2 inhibitor. But studies after Dr. Butler stated in TCT&D article, he mainly preferred the SGLT inhibitor to the non-STEMI patients and STEMI patients with left ventricular dysfunction after hospitalization after the 5 to 7 days of the hospitalization. So he stated in the article. So thank you for your attention.
Hi, thank you very much, Dr. Gambert. Very nice presentation, and well summarize the two pivotal trials entitled Reduce MI and Impact MI. So now this topic is open for discussion. So is there any comment or question from the panelists? So can I ask one simple question? So Dr. Gambert, so have you prescribed beta blocker for the patient with AMY with a good LVEF in the past, or do you change your clinical practice based on this result in the reduced AMI trial?
Yeah. Of course, beta blocker is best friend of the cardiologist. Yeah, I have prescribed the beta blocker for purpose to reduce their ischemic symptoms, and especially I use as an anti-anginal effect to use this effect. But from this trial, we saw that there is no difference in the patients with indications for beta blocker, like tachycardia or other arrhythmias, and chest pain or angina pectoris, etc. So so it's impacting on my clinical practice. Yeah.
Thank you very much.
May I?
Thank you.
Okay, please go ahead.
Yeah, I think I concur Dr. Gambert's interpretation on the reduced MI. I think nowadays the very quickly and timely intervention probably changed the whole picture of myocardial infarction care. So I think in patients with a very timely reperfusion, a good LV function, no clinical symptom or signs of heart failure or ischemia, probably the significance of beta blocker is getting less. But one thing I'd like to comment on the reduced MI trial is that the beta blockers they are using include both metoprolol and the bisoprolol. So these are two different beta blockers. We all know that beta blockers should not be considered as a class because some are short-acting, some are long, some had intrinsic sympathetic activity. I think all these should also be taken into consideration. That is my comment for the reduced MI. But like I said, with a very timely reperfusion, maybe the importance of beta blocker is getting less and less in the current era.
Yeah, I totally agree with your comment. So is there any other comment or questions from the panelists?
Well,
So okay, go ahead.
Same thing happens with the impact AMI. I think currently the medications are so good. So to have any significant improvement on the death is very, very difficult. And also, I think the COVID pandemic also affected the trial. You see, the composite primary endpoint is death and hospitalization. But during the pandemic, a lot of patients actually do have worsening heart failure, but cannot be admitted. They simply increase their diuretic dose or things like that. And then that's considered a AE rather than an endpoint. So I think this will also affect the interpretation of the trial. This is reflected on the actual risk for those groups of patients. The numbers of events are much lower than the pre-trial calculation for the sample size. So I think pandemic also had some impact on the trial result.
Yeah, thank you very much for the nice comment. So Dr. Gambat, is there your additional comment?
Yeah, I have a comment. For impact MI trial, there is one point is SGLT2 inhibitors usage. After the early phase of the acute myocardial infarction, there is another influencing factors to death. There is mainly stent thrombosis and mechanical things, and arrhythmias is the main part of the cause of the death in early phase of the acute myocardial after the acute myocardial infarction. So SGLT inhibitor is mainly don't affect these changes. So it's also the one influential factor of the study's results. Yeah.
Okay, thank you very much. So Dr. Gambit, thank you very much again for your nice presentation and the comment. So now it's time to move to the second presentation. Okay, so second presenter will be Dr. Ray Albert Giabgan from Philippines. His topic title is antiplatelet strategy after stenting PCI for STEMI and non-STEMI ACS, DAPT or new P2Y12 receptor antagonist only for how long after ultimate DAPT trial. So please go ahead.
Right. Thank you, sir, for that kind introduction. So I will be sharing my slide. I hope you could hear me well.
Yeah, perfect.
Good afternoon, everyone. Thank you once again for inviting me to give a short discussion on antiplatelet strategies after PCI among patients who have had your ST elevation or non-ST elevation acute coronary syndrome, given the latest trials and the ultimate DAPT trials. So is it still dual antiplatelet therapy, or can we shift now to the new P2Y12 receptor antagonist only after 1 month of dual antiplatelet therapy? I have nothing to disclose. This would be the outline of my talk for this afternoon. So we would be revisiting the current recommendations for ACS after PCI. We would discuss some of the current evidences that talks about abbreviating your dual antiplatelet therapy, and then take a glimpse of what the ultimate DAPT trial now says about abbreviated DAPT for patients who have had ACS and primary PCI. And then later on, we will delve into the decision making of whether or not our patients could now be given your single antiplatelet therapy instead of your dual antiplatelet therapy, or should we shift at all? Okay. So these are some of the concerns with regards to your current ACS guidelines. So not really much of a concern, but rather the recommendations that have been provided to us have been recommendations that has existed for several years. So for the recent ACS 2023 guidelines by the ESC talks about maintaining dual antiplatelet therapy for at least 12 months as standard treatment for patients who have had an ACS, and 6 months for patients who have had chronic coronary syndrome and underwent revascularization. Now, there are some recommendations with regards to the risks of the patients for bleeding. So for patients who have high bleeding risk, the recommendation is to abbreviate your dual antiplatelet therapy to single antiplatelet therapy after 1 month. But there are also currently some studies that talks about abbreviating our dual antiplatelet therapy after 3 months or after 6 months, depending on the patient's bleeding risk, as well as depending on the patient's ischemic risk, and also depending on the assessment of the physician providing the dual antiplatelet therapy. So how much evidence is there really with regards to a reduction of MACE once the patient has been shifted to single antiplatelet therapy in patients with ACS? And can we really abbreviate dual antiplatelet therapy in patients who have low bleeding risk? Because most of the studies that have been included in the guidelines involve patients or talks about patients who have relatively high bleeding risk, hence the need for us to abbreviate dual antiplatelet therapy. So what are the recent evidences that talks about abbreviated dual antiplatelet therapy? Okay, so one of the recent studies that has been made available to us is the Stop the APT to ACS trial. So it's a short and optimal duration of dual antiplatelet therapy study among patients who have had ACS. For this particular study, they enrolled adult patients who underwent primary PCI with a cobalt chromium everolimus eluting stent. And then they excluded patients who were in need of anticoagulation, those who have a history of bleeding, and those who have known clopidogrel intolerance or resistance. So the intervention that they did was to shift these patients into patients who continued the standard therapy with of DAPT for 12 months and compared it with patients who would be given only dual antiplatelet therapy for 1 month and then shifting it back to just single antiplatelet therapy with clopidogrel. And the outcome that they were looking at was non-inferiority in terms of MACE and superiority in terms of reduction of the risk of bleeding. So this was a multi-center study conducted between 2015, 2017, open label and randomized clinical trial. So what they found after 12 months of follow-up was that the rates of your major adverse cardiovascular and cerebrovascular events were not significantly different in terms of ischemic outcomes between the clopidogrel group and the dual antiplatelet group. Okay, so what they did find was that there was a significant reduction in the rates of bleeding among patients who were on clopidogrel monotherapy compared to those who were on dual antiplatelet therapy. So if we're going to look at the chart to the right of your screen, you would see that that the rates were indeed significantly lower in terms of the cumulative risk of major and minor bleeding between patients who were maintained on single antiplatelet therapy with your clopidogrel versus those of the patients who were maintained on dual antiplatelet therapy, while the rates of ischemic events were slightly a little bit lower for patients who have been on single antiplatelet therapy. But one of the things that we could derive from this is the baseline characteristics of the patients who were included in the study. So if you're going to look at it, most of the patients were men. And most of the patients who underwent revascularization or PCI in this study were patients who had stable coronary artery disease or your chronic coronary syndromes rather than patients who have ACS. Patients who had ACS in this study made up only about 38% of the population. If you're going to look at the other details in terms of what vessel was revascularized, as well as the procedure that was involved, you would also notice that it was mostly single vessel disease, and there were only very few patients who underwent left main stenting in this particular study, only about 2.7% overall. And the procedure was IVUS guided, meaning that the stents that were used here were of correct size, optimal size. It was well, it was shown to be well opposed and well expanded stents because it's IVUS guided. Okay. Other things that we can note is that the procedure that was performed here were relatively uh, lower risk procedures, meaning there were only very minimal bifurcation lesions. There were only very few CTOs that were performed in this study, and also very few patients who have had revascularization of two or more blood vessels. So these characteristics tells us that most of the patients that were included in this particular trial, your Stop the APT2 trial, were actually patients who have low to intermediate ischemic risk. Okay, so meaning they were expected to have lower event rates even after 30 days. So based on the characteristics, most of the patients again were patients who had stable coronary artery disease. About 34% already had a prior PCI, about 13.5% had a prior MI. There were less than 50% of the patients had diabetes. Only a few patients had heart failure, and less than 10% of the patients had chronic kidney disease. But if you're going to look at the outcomes of this particular study, you would see that it really does favor towards shifting patients to single antiplatelet therapy after 1 month, for as long as they did not have any events during the first 30 days after the PCI that they performed. But note again that these are patients who have low ischemic risk. Now, what about the Master DAPT trial? It's another study, talks about the management of high bleeding risk patients and then performing PCI with the bioresorbable polymer coated stents, and then abbreviating the dual antiplatelet therapy to single antiplatelet therapy after 1 month. So they included patients both who had ACS and those who had CCS and underwent PCI with the stent mentioned. But the patients had to have at least one risk or one or more criteria for high bleeding risk. The intervention that was performed was again shifting the patient from dual antiplatelet therapy to single antiplatelet therapy after 1 month, and then comparing it with patients who were stratified to receive standard therapy for at least uh, 3 months if on anticoagulation or 6 months if without. So the outcome that they were looking for were the outcomes of death, MI, stroke, bleeding, as well as your major adverse cardiovascular cerebrovascular events. So this was an RCT open label. So after about 335 days of follow-up with these patients, what they did find was that in terms of adverse events, the abbreviated therapy did not differ with that of your standard therapy. The rates of your major adverse cardiovascular as well as cerebrovascular events, comparing it between your abbreviated therapy and your standard therapy, also did not show any significant difference. But in terms of bleeding, what they did find was that there were again lower rates of bleeding among patients who had abbreviated therapy compared to those who received standard therapy. So in comparing this study with the previous study that we talked about, we would see that this particular study consisted mostly patients who have had ACS. And the difference now is that they included patients who had high bleeding risk. But what is important is that it was able to show that even with an abbreviated dual antiplatelet strategy, shifting from a DAPT to a single antiplatelet therapy after 1 month showed that it was not inferior in terms of adverse events, while at the same time it's able to significantly reduce the risk of bleeding among patients uh, receiving your antiplatelets. Okay, so what about the ultimate DAPT trial? How does it differ in the previous studies that has been taken into consideration when the ESC guidelines were made? So the ultimate DAPT trial is a ticagrelor alone versus ticagrelor plus aspirin for 1 month to compared to 12 months of dual antiplatelet therapy after PCI in patients with ACS. So the population consisted of patients who were 18 years or older who had ACS, who had no major ischemic or bleeding events or events within 30 days with dual antiplatelet therapy. The intervention done was, as mentioned previously, it's ticagrelor plus a placebo versus ticagrelor plus aspirin beginning 1 month comparing it to the standard therapy. So the outcome that was being monitored here was superiority in terms of reduction in the risk of bleeding and non-inferiority when it comes to major adverse cardiovascular cerebrovascular events or your MACE. So it was a multi-center study intended to include patients from China, Italy, Pakistan, and UK. However, for this particular trial, most of the patients, about 98% of the patients who were included in the ultimate APT trial were from China. It was a double-blind placebo-controlled trial. So in 12 months after follow-up, they were able to complete about 99.9% follow-up for these patients. And what they found was that clinically relevant bleeding was again significantly lower among patients who were on single antiplatelet therapy or your SAPT compared to those who were on dual antiplatelet therapy with ticagrelor and your aspirin. What is important is that even with just an abbreviated treatment, they were able to show that the rates of ischemic events in terms of your MACE did not differ between the single antiplatelet therapy with ticagrelor alone compared to those patients who were given dual antiplatelet therapy. Okay. So here is the graphical representation to your left, showing again that the rates of clinically relevant bleeding was significantly lower among patients who were on ticagrelor alone or ticagrelor with placebo compared to those who were on standard dual antiplatelet therapy. And if you're going to look at the major adverse cardiovascular and cerebrovascular events, you would see that there was really no significant difference between maintaining patients on single antiplatelet therapy compared to maintaining them with dual antiplatelet therapy for 12 months. Okay. So the benefit that they were able to show was across the board, regardless of the age of the patient, the sex or the gender of the patient, regardless of the comorbidities of the patient that was involved in the trial. So what's good about this particular data is that for us Asians, it gives us really data to say whether or not it's applicable to our setting, given that most of the patients included in this study were Chinese. Okay. But again, just as what we do with most of the studies that comes out, we have to dwell deeper into the contents of the trial. Are the baseline characteristics of the patients included in the trial applicable to our patients? So for this particular study, the baseline characteristics that I found interesting were as follows. So most of the patients, again, were about 63 years old, median. So most of the patients were men, about 74%. Most of the patients here were had STEMI or NSTEMI, and the rest had unstable angina. So, with the regards to the question of whether or not to maintain a patient on single antiplatelet therapy after 1 month, in patients who have had primary PCI after ACS, this is a particularly good reference for us. Most of the patients here were hypertensive, and there were again only about 31.8% patients had diabetes, and 8% had insulin were on insulin. There are again few patients who had CKD, only 6.4 patients had heart failure, and only 10% of the patients had PCI. So most of the patients who underwent this study underwent it with only had only single vessel PCI. And most of the stents was less than 2 stents, at least 3 millimeters in diameter and less than 60 millimeters in length was the uh, average or usual size of the stents that were used for this trial. And it was not mentioned previously, but again, in Ultimate DAPT trial, the study involved patients who underwent IVUS-guided PCI. So again, that means that the stents that were used were optimal in terms of the size and length and in terms of deployment of the stent. All of them were IVUS-guided. So if we're again going to look at this baseline characteristics of the patient, and we were going to compare it to the table to the right, which talks about risk factors for ischemic events to determine whether or not we're going to maintain a patient on dual antiplatelet therapy for a long period of time. You would see that the baseline characteristics of the patients included in the ultimate DAPT trial were patients who again were of low ischemic risk. So how do we decide whether or not we keep a patient on dual antiplatelet therapy or we maintain or we shift the patient to just 1 month of dual antiplatelet therapy and then abbreviate it to single antiplatelet therapy? So when we decide whether or not to maintain SAPT or do DAPT as standard therapy, we have to take into consideration a variety of things. So one of the takeaways that we could get from the ultimate DAPT trial is that we have to make sure that there were no ischemic or bleeding risks that happened within 30 days after the procedure. We have to be able to balance the rates of the risks of ischemia with the risks of bleeding so that we would be able to have a living patient with a low risk of developing recurrence of MI. We also have to take into consideration the blood vessel that is involved in our patient. If our patient only has a single vessel disease and we only have to do revascularization for just a single vessel, whether it be your LAD, LCX, or RCA, then we may be able to consider single antiplatelet therapy provided that the other factors, other ischemic factors, are also within acceptable limits. But if the patient has a left main stent, it's underrepresented in the ultimate DAPT trial. So if we deployed a single stent, but it's in the left main, then we might have to think twice about maintaining the patient or trying the patient on single antiplatelet therapy. We also have to take into consideration the complexity of the PCI. We do know that the more complex the PCI, the greater is the ischemic risk. The more stents that we deploy, the more complex the procedure, the smaller the stents that we deploy, the greater is the risk of ischemic events, restenosis, or in-stent thrombosis. And also note that for most of the patients who were included in the study, it was an IVUS-guided procedure. So an IVUS-guided procedure helps us optimize the size, the length of the stents that we need in when we revascularize our patients. So we have to be sure that after primary PCI, that all our stents are well optimized. It's well opposed and properly deployed. So at the end of the day, when we talk about whether we maintain a patient on single antiplatelet therapy after 1 month or continuing dual antiplatelet therapy, we have to individualize treatment. While the ultimate DAPT trial does give us a glimpse of the possibility that we can soon um, consider abbreviating our dual antiplatelet therapy for ACS patients who have undergone revascularization for as long as they have low ischemic risks. It is still important to individualize treatment. One of the ways in which we would be able to also assess the risks of or balance of the risk of bleeding with the rates of ischemia is by using your precise DAPT calculator. So to your right is an example of your precise DAPT scoring, wherein you just input the patient's data, or they ask you for the patient's hemoglobin, the patient's history of bleeding, the patient's age, and etc. And it would be able to compute the patient's risk of bleeding and compare it with the risk of ischemic events. So this is one of the ways in which it would be able to help us determine whether we maintain a patient on just 1 month of dual antiplatelet therapy and then shift them to single antiplatelet therapy, or should we extend it, or should we continue standard therapy. Okay, so basically the summary would be for us to individualize treatment and to compare our patient profile with the baseline characteristics of the patients that had been included in the recent studies that has been made available to us. So with that, I add my talk, and thank you once again for allowing me to share or to talk about this topic. Thank you.
Okay, thank you very much for your great presentation. So now this topic is open for the comment and discussion. So is there any opinions from the panelists? So Dr. Kabigan, do you remember what types of stents were used in the ultimate DAPT study?
They I wasn't able to get actually the type of stent that they used, but most of the stents that are currently being used for abbreviated therapy were actually the newer generation stents. They were the thinner struts, thinner profiles of stents that were being used, just as what was done with the other previous studies that they had in the past.
Oh, thank you very much. Yeah, because the stop DAPT2 ACS trial, the only ever demonstrating stent
Yes.
with a durable polymer were used. So anyway, is there any question or comment from the panelists?
Yeah, may I? Wonderful presentation, Dr. Cavigan. I think the issue you have mentioned, also raised by Dr. Minami here, is that currently the PCI is a different procedure from maybe 10 years ago.
Yes.
First of all, the stents we are using now are thin strut, less dose load, more flexible, newer versions of stents. And secondly, the operator is more conscious about the result. So we use whatever we have, IVUS, OCT, to maximize and optimize our stent result. I think the combination of both actually give us the space or room to actually shorten our DAPT. Because like Dr. Gavin had mentioned, 1 month is a critical crossover, because at 1 month, in theory, the endothelium is grown, and then afterwards, only bleeding risk is the concern. So I think as long as we are sure that the stent result is optimal and we are choosing the correct stent, I think in theory, a short DAPT is beneficial for the patient.
Yes, I would agree, sir. There has already been a lot of advancement in terms of the stents that we are now using. Most of the studies that did mention about reducing ischemic risks after PCI were actually referring to older generation stents. And with the advent of this, with our IVUS and OCTs, our visualization of how well we are able to deploy our stents and size our stents is a lot better now compared to how it was years ago. So it does provide a good avenue for us to hopefully one day have even greater evidence to tell us that we can now abbreviate safely the antiplatelet therapy from for after just 1 month. But still, it's important, I think, that we also individualize treatment still for most of our patients who have undergone primary PCI.
Okay, thank you very much.
Thank you.
So it's now time to move to the third presentation. So thank you very much, Dr. Kapgan again. So Could you please show the, yeah. Okay, so let's move to the third presentation. It will be provided by the Dr. Sakulwat Montribade from Thailand. The title of his topic is a preventive PCI for non-obstructive, non-flow limiting, high-risk vulnerable coronary regions, implication of PREVENT trial. So please go ahead.
Okay. All right. Thank you so much for your kind introduction. Okay. Let me share my screen. 1 second. All right. All right. My name is Dr. Sakulwat Montribade from the Police General Hospital, Bangkok, Thailand. So my topic is about preventive PCI in the vulnerable coronary lesion, the implication of the PREVENT trial. Okay. So my outline is like this. First, I will show you our case example and the three of this outline, okay? So this is my case. So a 50-year-old woman, high blood pressure, hyperlipidemia, presented with shortness of breath. Exercise stress echo is negative, but this is slight depression on the EKG, and the patient was very concerned. So we brought the patient to do angiogram. Basically, there was a mild and moderate stenosis at the ostial of LAD. Okay, and at that time, I need to decide whether to use an FFR or OCT because of the reimbursement. But my gut feeling is that we may need to do PCI on this lesion, so I opted to use imaging instead of FFR at that time. And this is the OCT result. Basically, the distal reference was 3O, and that was a fibrolipid plaque with thicva at about the proximal LAD. And here's the ostial LAD that is involving into the carina. And this is the left main. So here is the thicva, a vulnerable plaque feature with thin cap fibrotrauma. And also the MLA is less than 4. Okay, so I will show you my my treatment at the end of our topic. Okay, so what is the vulnerable plaque? One is a plaque that is prone to disruption, leading to acute occlusive thrombosis, or two, a plaque that is prone to rapid progression, leading to worsening angina. So if we do preventive PCI, the first one will be to prevent future MI and death, and the second one will be to prevent future ischemia and angina. Okay, so we use plaque phenotype such as thicva, lipid plaque, and all that, together with plaque burden, the degree of plaque deposition, especially the plaque burden as in the area, to identify the vulnerable plaque, right? Especially, this is from the PROSPECT trial. We know that thicva, MLA of less than 4 and plaque burden of more than 70% increase the risk of MACE. However, from the PROSPECT trial, most of the outcomes are angina and not MI from the first trial. And this is a PROSPECT 2. They incorporate the use of NIRS IBIS. So with high lipid core burden index, it increased the risk of MACE, and this time it is also increased the risk of MI. So here is a true outcome of the vulnerable plaque: increase the risk of MI and also angina. Okay. From combined OCT FFR trial, so the lesion with FFR negative classified into if the lesion has thicva or not. Thicva, when it is positive for thicva, it increased the risk of combined primary endpoint together with 18-fold increase the risk of MI. So thicva is one of the real feature of vulnerable plaque leading to MI. Okay, from the meta-analysis, basically 4 major characteristics of vulnerable plaque: plaque burden of more than 70%, thicva, large lipid core, and MLA of less than 4. Okay, so 4 of these features increase the risk of MACE. If we take a look from a different angle, from CT coronary angiogram, CTA, these are the feature that has a relationship with increased MACE. Basically, this is a high risk feature from CTA. My second topic is can OCT reduce vulnerable plaque? So the first trial is reversal trial, comparing the use of high-intensity statin, atorvastatin of 80 milligram, compared with pravastatin of 40 milligram. LDL was reduced from 150 to about 80 compared to 110. Okay, so only the atorvastatin arm plaque progression is slow. Okay, but from this trial, they cannot find the plaque regression, only just to prevent plaque from progression. But the later trial, like this one in the New England Journal, the Saturn trial, comparing the use of both high-intensity statin, rosuvastatin compared with atorvastatin 80, LDL reduced to 70 compared to 60, and both resulted in plaque regression. Okay, and more plaque regression can be observed in the rosuvastatin group. When we try to see the use of ezetimibe added on to atorvastatin, lower LDL from 108 to about 70 versus 63. In the ezetimibe group, we can appreciate the lower plaque volume, of course, the plaque regression, more in the lower LDL group. And when we comes into the era of PCSK9, evolocumab use lower LDL to 36, we can even lower, even have appreciated more plaque regression in the PCSK9 group. And also in the alelocumab group, not only we can appreciate the plaque regression, we can also achieve reduction in the lipid core burden index and also increase the fibrous cap thickness. So in conclusion of the OMT, the lower LDL is the better to achieve more plaque regression. And also in the PCSK9 group, we can appreciate increase in the fibrous cap thickness. So back to our topic of, can we use preventive PCI to prevent future events in those plaque? The first one that we have studied is the prospect absorb trial that include patients with troponin positive ACS, and they fix the first culprit region and interrogate all three vessels using IVUS and NIRS, and include the lesion with non-flow limiting. Okay, so diameter stenosis of less than 70% and FFR or AFR negative, randomized to the use of absorbed BBS compared with the GDMT. From this trial, the outcome are the angiography outcome and the IVUS NIRS follow-up, and is not powered for clinical follow-up. Okay, so this is the plaque feature from this trial. So as you can see, there's a lot more. This is about 70%, 80% high in the plaque burden, and also about 50% lipid core burden of more than 324, and also the MLA of less than 4 in 80% of the case. So this is the feature of vulnerable plaque in this trial. So the result, only the angiographic result is the main outcome. So a large MLA can be observed in the BVS group and markedly decrease in the lipid core burden index in the BVS group. However, we have a trend in the better MACE in the BVS group, but this trial is not powered to detect this outcome in the MACE outcome. So now we come to the PREVENT trial that just recently published in Lancet. So this trial, they include lesion with stenosis of more than 50% with negative FFR of more than 8, together with 2 out of 4 feature of vulnerable plaque. One is MLA of less than 4, plaque burden of 70%, PICVA by OCT or the RF-IVUS, and lipid-rich plaque by NIRS, randomized to either preventive PCI with BBS or later on the everolimus stent DES, and compare with just OMT. the primary endpoint is target vessel failure at 2 years. So like I said, the main inclusion criteria is as this. Okay, so the vulnerable plaque for feature are here. And the lesion, they only include the diameter of 2.75 to 4 and lesion length of less than 40. So not a very complex lesion included in this trial. Here is the baseline characteristic. Okay, so first thing that I wanted to point out is most of the patients here presented with stable angina or silent ischemia in about 84%. So mainly chronic coronary syndrome, and only about 15% ACS included in this trial. And for the vulnerable plaque feature, 97% use plaque burden together with MLA criteria to define vulnerable plaque. Only 27% use high lipid core burden index, and only 7% use stigma, either from OCT or radio frequency IWIS. So a little bit more in the about plaque burden and MLA, and not lipid core burden and stigma. Okay, the main lesion that included in this trial, 50% are in the LAD and the rest are in RCA and circumflex. And the size of the vessel, target vessel, is about 3.0. This is the main outcome. Basically, there are significant decrease in the primary outcome of target vessel failure, both at 2 years and also at 7 years. So hazard ratio of about 0.5%, so about 50% reduction, okay, in the target vessel failure at 7 years. But if we take a look in the in each of the outcome, so the main outcome that drives the primary outcome is target, ischemia driven target vessel revascularization and angina. Okay, so the risk of MI and death are low in this trial, and they cannot show the significant difference in the death and MI in this trial because of the low event rate in terms of MI and death. So only target vessel revascularization and angina can be significantly show that the difference here in this trial. Okay, if we take a look in the subgroup analysis, you can see that in the multi-vessel disease, which they did PCI of the first vessel and then randomized the second lesion in the trial, there is a trend toward better outcomes with preventive PCI in multi-vessel disease. And also the second thing is the more severe lesion, there's a trend also that PCI may be better. And lastly, the use of DES, because BES scaffold is out of the market now, and the number that are included in this trial are not as high compared to the use of DES at the end of the study. So in conclusion, what we learned from the trial, so first, if we have non-flow limiting lesion, okay, like 50% stenosis and FFR negative, but if the lesion is flow limiting or FFR positive, we can do PCI and achieve better outcomes the same way in FAME or FFR trial. So if we have non-flow limiting lesion, we have an option to interrogate this lesion using intercoronary imaging and see if the lesion has vulnerable plaque feature, okay, MLA, plaque burden, TIGFA, and NIRS. Okay, but we need to use intercoronary imaging. So that's one of the caveats of defining vulnerable plaque. So if there is no vulnerable plaque feature, OMT, of course, and we need to aim for very, very low LDL, okay, less than 70 or even lower than that to achieve plaque regression. And lastly is the intracoronary imaging can define vulnerable plaque in our lesion. If we do preventive PCI, we can reduce target vessel failure and revascularization and angina, but not MI at this point. Okay, and we need to in addition to PCI, we need also to give the patient OMT with a very low LDL target. And lastly, if we do stenting, we need to use intracoronary imaging guidance because those lesions are non-flow limiting. So if we need to achieve perfect result of stenting, so we need to use intracoronary imaging to optimize our stenting. But we also need to weigh against the risk of PCI, not too complex procedure, not too complex lesion. DAP use is one of the factors that we need to consider because if the patient has high bleeding risk, we do more PCI, we may force the patient at a longer depth, and also the cost of preventive PCI, especially we need to use intracoronary imaging, and also we need to do PCI with stenting in those lesions that is not severe at that point. So back to my case. So at a time, as I can appreciate the low MLF less than 4 and thicva, so we go ahead and do a PCI of the ostial LAD because there's a plaque involving into the carina, so I opted to just stent cross over from the left main to LAD and then recross into circumflex, do a pot, side pot, and finish it up with a final pot of 4-row. And this is the final result. Basically, we fixed the ostial LAD, cross over into the left main. So on the LCT, we can appreciate that MOA is larger, and we hope that the patient may not have the any angina and revascularization in the future, the same way as in the PREVENT trial. Okay, so my take-home message are: one is the major characteristic of vulnerable plaque, as I mentioned, the 4 of this. OMT is still the key. Preventive PCI may be of benefit, but we need more studies to confirm, to prove the benefit of preventive PCI in a more complex lesion, and also to prove if it can prevent death and MI in the later study if we have one. Thank you so much. This is all of my topic.
Thank you very much for your nice presentation. So now this topic is open for the discussion. So is there a comment or the question from the panelist?
May I?
Okay, please go ahead.
Dr. Mangdrum, nice presentation, and I totally agree with you, and thanks for your review, and I appreciate it very much. Just totally agree with you. Thank you.
Hey, this is Dr. Ronnie Shantu from Cleveland Clinic in Abu Dhabi. One thought I think a lot of these trials leave out is functional testing. And so, for example, these are cases of patients who come to the cath lab with angina or abnormal stress testing, and they're actually found to not have a significant lesion. In my mind, there's sort of two different topics. You have vulnerable plaque. You're trying to prevent something, and this is where the ongoing data is. But however, we have symptoms. And so I really find, without doing functional testing, invasive functional testing, looking for microvascular dysfunction, looking for coronary spasm, looking for microvascular spasm, it's really hard to say if we're really treating the patient complete. We started doing functional testing about 2 years ago now, and it's completely shifted our practice and our mindset. And I highly encourage, all the centers to incorporate that as part of their routine approach. We have anywhere from 20 to 30, even higher, 40% of patients come to the cath lab without any obstructive disease. About almost 50% of patients post-PCI continue to have angina. So I'm not sure we're really treating the lesion sometimes when we are, just because it's obstructive or even if it's non-obstructive. So just my thought in regards to a lot of these trials. I do find, contemporary trials really should incorporate this, and we're really only testing half of the picture here. And the other question I did have is, did the PREVENT trial, the system hung up a bit, did it actually show where our LDL targets were? Because I think without having a trial that looks at preventive stenting, that really should be done with an LDL clearly below 55 or 1.4. I mean, that really should be the trial because we're really comparing optimal medical therapy versus not. And so I'm just curious if the trial did show where the LDLs were.
So the LDL in the trial is about 60 in both of the groups. That's 60.
Well, may I? Because I'm one of the co-investigator of the PREVENT trial. So actually, both groups are under very enormous emphasis on the OMT. So actually, we tried, according to the local regulations, our best to achieve the OMT in both groups. So I think the trial gives us a new idea, which is, after the FAME study, everybody believes that the physiology can identify the culprit lesions. But specifically, we look for those FFR negative lesions showing vulnerability and then treat them preemptively. So the idea of PREVENT is to prevent plaque rupture. So it's to prevent acute events. It's different from the idea of a ANOCA, which was mentioned earlier, where you thought you have treated the culprit, but then the patient is still suffering from angina. That is something maybe to do with the microvascular dysfunction or other diastolic problems, but it's a different topic or focus towards the vulnerability of the plaque. But obviously, a vulnerable plaque needs to be treated both by best medical treatment and probably preemptive PCI. Because by PCI, we are actually bringing in a new endothelialization so that the plaque may be stabilized. That is the hypothesis. So the overall PREVENT trial can be considered as a hypothesis generating trial. I believe that in the future, we do need larger study and also to look at the longer events. But in the PREVENT, we did demonstrate that in 2 years, we have reduced the clinical event by treating those lesions preemptively. Yeah.
Yeah, thank you very much for the nice comment. One point of the PREVENT trial is this study mainly included stable patients, right? So in general, it's easier to stabilize plaque in patients with acute coronary syndrome. So it may be more difficult to stabilize the plaque in patients with stable patient. So right, yeah. So PREVENT trial showed a very wonderful result, but we are not still uncertain if this kind of the result can be obtained if the study was conducted in patient with acute coronary syndrome. Is my comment.
Well, we did include some of the ACS patients, but it's not a completely ACS patient cohort. It's about 20-30%. Yes.
Right. Yeah. I mean that. Yeah. The plaque in patient with ACS can be easily stabilized by the OMT, right? Yeah. So to show the significant difference may be more difficult.
There is an old saying that you have a vulnerable plaque in a vulnerable patient. So actually in ACS, maybe all the plaques are unstable because of the systemic inflammation or any kind of biological process. So I think medication-wise, not just LDL lowering, but maybe in the future, we will also be looking at some inflammatory directed treatment, as well as the lipoprotein little a lowering agents. So it's a very complex issue regarding vulnerability.
Yeah, thank you very much. Yeah, anyway, we have to still wait for more data to apply this result to the daily clinical practice. So thank you very much. Yeah.
I think it's time to actually let me introduce our next speaker. We want to move on time according to the schedule. So I have the honor to introduce our next speaker, who is the co-host of this webinar, Dr. Yoshiyasu Minami. He had introduced himself already. He's from Kisasato University Hospital. And the topic today for him is complete or culprit-only coronary revascularization for STEMI with the multivessel disease, a controversy in full revasc versus fire. Professor Minami, please.
Okay, thank you very much. So, okay, my topic is a complete revascularization in patient with HCS. So this is my disclosure. And as you know, the complete revascularization versus culprit only PCI is a very important topic. Then there have been several studies investigating this topic among patients with STEMI. So if we put the results of those studies on this table, so all previous 5 pivotal trials are located in the right side, meaning that complete revascularization is better than the culprit-only PCI in terms of the clinical outcomes in the clinic phase. So among them, one of the pivotal trial was the complete trial. So as you may know, a total 4,000 patients were included in this trial and randomly assigned one by one into complete revascularization or culprit-only PCI. Then our results were very simple. The left side is the primary endpoint and the right side of the secondary endpoint. And in both endpoints, complete revascularization is better in terms of the incidence of adverse cardiovascular event. So as you know, the current EU guideline strongly recommend the complete revascularization for the patient with STEMI with class 1. And also for the patient with non-state ACS, with class 2A. Then after the revision of this current EU guideline, 2 additional those major studies were presented. So one is this FIRE trial. So this trial is aiming to test the benefit of complete revascularization in elderly patients with STEMI or non-STEMI. So this is the inclusion criteria. So this FIRE trial included the patient with the age more than 75 years old, STEMI or non-STEMI, and of course the MACCE-based disease and the successful treatment of covered region. Then total about 1,400 patients were randomly assigned into culprit-only or the complete. Then primary endpoint was later patient-oriented composite endpoint, including the all-cause death, myocardial infarction, stroke, and revascularization. The median age of was 80 years and 81 years in both groups. And this is the important findings. And STEM patient was 35%, and non-STEM patient was about 65%. And most patients didn't have heart failure, and mean value of the LVEF was about 49%. Then the about 2/3 of the PCI from the non-carbureted vessel were performed during the index procedure for the carbureted vessel. And another 1/3 of the PCI for the non-carbureted vessel were performed later, mainly within 3 or 4 days after the initial PCI for the carbureted lesion. Then in this trial, most patients were physiologically assessed by using the wire-based hyperemic index, the wire-based non-hyperemic index, and the angiography-based index. So anyway, most patients were physiologically assessed. Then about a little bit less than half of the patient showed functionally significant. And finally, 45% of non-culprit vessels were treated by PCI. So these are the main result of this FIRE trial. And the left side is the primary outcome, and the right side is a key secondary outcome. Then, as you can see, the incidence of adverse cardiovascular event was significantly lower in patients with complete revascularization than the patient with culprit-only revascularization. So this is a figure showing the safety endpoint, including the contrast-associated acute kidney injury, stroke, or bleeding. Then, as you can see, the incidence was similar between the groups. So in conclusion, in these FIRE trials, among patients with the age more than 75 years old, with myocardial infarction and march vessel disease, physiologically guided complete revascularization was associated with a lower risk of composite endpoint of cardiovascular event. Then the authors mentioned several important limitations of this study. So one is this was the open label design. The second one is complete revascularization was guided by the physiological assessment. So they are uncertain if this result can be applied to the angiography guided complete revascularization. And also in this study, serum certain stent with ultra-thin strut was strongly recommended. So they are not sure this result can be applied for the different stent platform or different PCI strategy. So if we put the result of FIRE trial on this table, so FIRE trial is here. They're still in the right side with a completely better. So the percentage of the patient with non-STEMI is 65%, is a unique characteristic of this FIRE trial, in addition to the elderly patient. So number two study I'd like to introduce in my presentation is a full revasc trial. So this trial is aiming to show the benefit of the FFR-guided complete revascularization for the patient with myocardial infarction. So initially, this study planned to include a total 4,000 patients, and they'd like to allocate 2,000 versus 2,000 in each groups. Then in this trial, the non-culprit lesion was defined as a lesion with more than 50% stenosis on the angiogram. And the complete revascularization group was performed PCI by using the FFR guided. The versus culprit only strategy was the conventional management by using the OMT alone. However, this trial was terminated earlier than the initial plan. Then finally, the analysis was performed, including the less than 800 versus 800 in both groups. Then also this study included some patients with a very high risk non-STEMI, but mainly, the approaching 90% of patients were STEMI. Then this is important characteristics of this study. So surprisingly, in this trial, only 36% of non-culprit vessels were physiologically assessed by using FFR. Then FFR positive were about half. So finally, only 18% of non-culprit breaths were treated by PCI. So this is an important, characteristics of this trial. So this is the figure showing the primary endpoint, including the death from any cause and the new onset myocardial infarction and unplanned revascularization. And as you can see, there was no significant difference in the incidence in both complete revascularization group and culprit lesion only PCI group. So this is the result showing the key secondary outcomes, including the death from any cause or new onset myocardial infarction. As you can see, there was no significant difference. So this is another key secondary outcome, unplanned revascularization. And the incidence was a little bit lower in the complete revascularization group compared with the culprit lesion only PCI group. So this is a figure showing the safety endpoint. So as you can see, the incidence of contrast-associated acute kidney injury and the neurologic complications, stroke, major bleeding, and early hospitalization due to the heart failure were similar between the groups. So in conclusion, among patients with STEMI or very high-risk non-STEMI and MACCE-based disease, FFR-guided complete revascularization during the index hospitalization did not result in a lower risk of composite cardiovascular endpoint. Then, of course, the very important major limitation of this trial is it was stopped early for the feasibility and the ethical reasons. So if we put the results of this full revasc trial on this table, so this trial is located at the middle, completely different from other 5, 6 trials. So what can be the cause of difference in the results in this full revasc trials as compared with other trials? So as I mentioned that the physiological assessment was performed only 36% of non-culprit vessel, and the functional significant was only 17%. Then finally, only 18% of non-culprit vessels were treated by PCI in full revasc trial. In contrast, for example, complete trial included more severe lesions. Then finally, more than 90% of these moderate to severe lesions were treated by the PCI in the complete trial. So how about the FIRE trial? FIRE trial included the similar patient cohort regarding the non-culprit lesion. The stenosis are more than 50% to 99%. So the large difference is a physiological assessment. So in the FIRE trial, most lesions were physiologically assessed, and finally, more than 40% of lesions were treated by the PCI. So I'm not, quite sure the exact reason for the marginal result in the full revasc trial. So maybe the low rate of FFR assessment and low rate of PCI may be one of the potential reasons for the marginal result in full revasc trial. In contrast, FIRE trials, the nicely showed the benefit of the complete revascularization in elderly patient. And also this trial included both STEMI and STEMI, non-STEMI. So my final message is that result in these two trials may further support the clinical benefit of complete revascularization in patients with myocardial infarction. So thank you very much for your attention.
Okay, thank you very much, Dr. Minami, for your nice overall presentation. So I think the topic is open for discussion or comments from our panelists. Okay, well, if none, may I add some my personal perspective? I think if you put complete fire and the full revasc trials together, you will see something very interesting. Because in the complete, there's no physiology evaluation based on angio only. And in the complete trial, it shows that the non-culprit PCI actually is better than culprit only. And if you look at the fire trial, they use the functional assay, and about half of the non-culprit were treated according to the functional result. And they showed a reduced driven revascularization later on. So if you put this together, also remembering the prevent trial, its complete trial also included some of the prevent lesions. I mean, they don't do physiology, but they judge that the lesion is maybe significant and then treated. While in the full revasc, they use the functional assay, and they can prove that they will reduce future ischemic-driven revascularization. So maybe these these three trials can be put together and then viewed in a complementary fashion, meaning that in the ACS, STEMI or non-STEMI, in addition to the culprit, the other lesions we should think about its physiology significance as well as the vulnerability of the plaque. If one of these indicators are present, maybe treatment is needed. Maybe that's my the picture that I can take from these trials. But that's interesting.
Yeah, thank you very much. Yeah, I totally agree with the comment. I think, that we need both, the morphological assessment and the physiological assessment to determine what kind of region should be treated by the PCI. Okay, thank you very much.
Yes, yes. Do we have any more input? Well, also one of my thought is regarding the fire trial. The fire trial tells us that actually a full, complete revascularization, maybe it's good. But interventionally, sometimes we cannot achieve this easily. So what is the role of bypass surgery in the setting of ACS? If we can treat the culprit, but the non-culprits are so difficult or so complex or diffuse to be treated, should we treat the culprit and send the patient for surgical complete revasc, or leaving the culprit and non-culprit altogether to the surgeon?
Yeah, thank you very much. Yeah, that is also the very important point. And unfortunately, those kind of patients, who may require the surgical intervention was excluded from this fire trial. So yeah, we are not sure, but I think in the near future, that kind of study that may be the next target to know the right patient to decide right patient for the complete revascularization by PCI.
Yeah.
Thank you very much.
Yeah, so more scientific work to be expected. Okay. Okay. Do we have any more comments or questions? Okay. If not, may we move to the next? So let me introduce to you our next speaker. Our next speaker is Dr. Xu Rongchen from Taiwan. He is currently the director of cardiology in Far Eastern Memorial Hospital, and also the clinical assistant professor from National Yangming Medical University. His topic today will be immediate or delayed complete coronary revascularization in non-STEMI. Have we reached a consensus? Okay, so Rongchen, please.
Okay. Thank you for a nice introduction. And I think Professor Minomi and also the chairman has discussed my topic already. So let me share my screen. So in 2021, American guideline recommend class 3 indication for the STEMI case or non-STEMI case to perform the non-cooperative PCI. And also the European guideline that recommend in cardiogenic shock, we should treat the cooperative only at the primary PCI, and the STEMI case, the class 1 indication to complete revascularization, and also 2A indication for non-ST elevation acute coronary syndrome. Is the table of recommendations. So from the literature, we should review the cooperative shock trial published in 2017. If we treat with the MI with cardiogenic shock, then cooperative only PCI strategy has favorable outcome. And both in the all-cause mortality and also the renal replacement therapy. Cooperative only PCI has favorable outcome. However, we can see the subgroup analysis that maybe in the very young age patient, the multivessel PCI immediate complete revascularization may be beneficial. We can maybe accumulate more data or evidence in the future. And you can see the question that if we have the very top lesion, the non-cooperative lesion is chronic total occlusion, then leave it alone is the best strategy because the cooperative lesion only is better. And in that stage, in that era, that the mechanical circulatory support is not so popular. So the frequency of the MCS support is only below 30%. And you can see in the cooperative only group, the Impeller CP is more frequently used, about 30%, and the VA ECMO is more frequently used in multivessel PCI group. So Professor Minomi has mentioned that the complete trial has give the strong evidence that the in STEMI cases, we should treat non-cooperative lesions at the same time or within the 45 days. However, I want to mention that in the complete trial OCT sub-study, you can find a more vulnerable character in the obstructive lesions. So how about the complete revascularization in non-STEMI patients? There is a large observational cohort from British Cardiac Intervention Society. You can see the complete revascularization can reduce mortality at the median follow-up of 4 years. So how about the randomized control trial? The first randomized control trial focused on the one-stage or multi-stage complete revascularization in non-STEMI cases. That is the SMILE trial. So each group composed of the 260 cases. And you can see that if we treat with the one stage or immediate complete revascularization, we can reduce the target vessel revascularization, but not the CV deaths. Another trial, FIRE, randomized control trial, has been disclosed very clearly. is the physiology guided complete revascularization and the focus on the elder patient. The age is more than 75 to be included, and the median age is 80 years old. So it's very elder patient group. So, however, we can see that if we treat the complete revascularization, we can reduce the CV death and the myocardial infarction. And they include the STEMI and the non-STEMI cases. However, in the subgroup analysis, both groups show the favorable outcome in complete revascularization. Another recently published randomized control trial, BioVasc RCT, included the STEMI case, non-STEMI case, and the unstable angina. They compare the immediate complete revascularization versus the staged complete revascularization. Each group have the 760 cases. However, the study population exclude the cases with previous CABG patient and exclude the cardiogenic shock and also exclude the chronic total occlusion. We can see the procedure characteristics. In stage complete revascularization group, they use more frequently of functional analysis and also the intravascular imaging. And you can see the primary outcome and also the secondary outcome mostly favor complete revascularization. And the immediate complete revascularization reduced the myocardial infarction, the new onset myocardial infarction, mostly type 1 spontaneous MI. You can see the lower part of the right column. You can see the difference of the new onset myocardial infarction. The hazard ratio is 0.41. So there are some reasons to explain the final result. One is in non-STEMI cases, identification of the culprit lesions is somewhat difficult. So maybe we treat both the culprit and the non-culprit, then we will not miss any culprit lesions. Another factor is in the vulnerable patient, the acute coronary syndrome, the non-culprit lesions may carry more unstable features from OCT in the prior study. So both of the situations may explain the 59% lower risk of MI and the 39% low risk of unplanned ischemia-driven revascularization. And this study composed of about 60% of non-STEMI cases. However, there is some safety concern that the all-cause death is the 1.9% versus 1.2%, and the major bleeding is a little higher in the immediate complete revascularization. The statistic significance is not so is non-significant. So we can see the presentation, non-STEMI and the STEMI cases, and the renal insufficiency. If you have the advanced CKD, maybe you will try the strategy. So they have pre-specified the non-STEMI cases. So BioVasc trial has the non-STEMI published that each group are 460 cases. And I think the anatomy is not so complex because you can see the vessels with significant non-culprit lesions is only one. That means maybe you have one culprit lesion and another one vessel disease. However, the stage complete revascularization, the operators more frequently use the functional physiology study and also the intravascular imaging. And the total stents, including the index and the stage procedures, the stents number 2 to 4. So it also explains the anatomy is not so complex to complete the revascularization. So in the non-STEMI cases, you can see the immediate complete revascularization group, the any MI is only 1, and the stage completed revascularization, the number is 14. So the hazard ratio is very low, it's 0.07. So at the 30 days results, the immediate complete revascularization has more favorable outcome, including primary composite endpoint and the CV death and MI. However, at 1 year follow-up, the primary endpoint, including all-cause mortality, MI, ischemic-driven revascularization, and the CVA event, there is the statistical significance is non-significant. We can see the 10% versus 8%. However, in the secondary outcomes, MI and unplanned ischemic-driven revascularization were both reduced in the strategy of immediate complete revascularization in non-STEMI cases. So BioVasc trial, the subgroup of non-ST elevation ACS is a pre-specified group. So in this group, the 1 year, there is no difference at the primary endpoint. However, immediate complete revascularization lowered the MI and the unplanned ischemic-driven revascularization. So there are still, we need more evidence. STEMI versus non-STEMI, complete revascularization versus culprit only. What is the definition of complete revascularization? The residual syntax score equal to 0, or immediate versus stage completed revascularization? And how about the vulnerable plaque, TIFA, minimal lumen area, plaque burden, the OCT, or some imaging mortality like NEARS, IVUS? Cardiogenic shock, the corporate shock trial, the complete revascularization rate is only 25% to achieve 0 residual syntax score. And in cardiogenic shock, how about the role of mechanical support? And what is the specific lesions about the CTO, complex PCI, high syntax score, the role of cabbage, and the LDL? How about the what's the LDL goal? The role of PCSK9 inhibitors, small interference RNA, or any new anti-inflammatory drug, and the extreme of OMT. So there are ongoing trials. Some has been published. I'm interested about the immediate OCT guided complete revascularization, and also the non-flow limiting vulnerable plaque at OCT. So this is the daily case. We have the non-STEMI case, triple vessel. We performed the rotational atherectomy at 2 vessel and put 6 DES to triple vessel. We performed the immediate complete revascularization under mechanical support. And we need also to treat the post-MI complication as well. Thank you for your attention. That is my share.
Okay, thank you, Dr. Xu, for a nice presentation. So you can see, obviously, some of the topics are actually interacting to each other. So very interesting. So the talk is open to discussions, comments, and questions.
So can I give a brief comment? So regarding the STEMI patient, last year, as you may know, the multi-study AMI trial clearly demonstrated that immediate revascularization was better than the stated PCI, right? So yeah, more simple, you know, in patient with STEMI, but for the patient with non-STEMI and ACS patient, the discussion will be more difficult. So no, you know, the clear randomized prospective trials so far. So we have to, you know, the find out many results from many trials, and then we have to consider what is the best way or something like that. So we need more data, right?
Yes.
Thank you.
Well, I like to say something about my personal thoughts on the topic. We discussed about the immediate or staged procedure, but how immediate is immediate? I mean, if you look at the curves after a ACS, probably the first 1 month, is when the patient is more vulnerable, and maybe the so-called non-culprit lesions may cause problem during that period. But usually after 1 month with the current medical treatment, most of the lesions, even not intervened, may be pacified or stabilized. So I think if we are talking about staged, should we define it to be a procedure that is later than 1 month? Anything occur, I mean, from the index state to maybe 1 month, should we call this a immediate or a, upfront complete revascularization?
Because the BioVax trial, the stage procedure is the median day from randomization to stage procedure is only 15 days. So
yes.
Yeah, 15. So they early to perform the stage complete revascularization. However, the MI on spontaneous MI is still different from the study. So maybe we should in the index hospitalization, we should define the immediate, maybe less than 7 days or less than 5 days. Yeah. So
yeah,
it's
so you have these index hospitalization and also the index first procedure. And there could be some discrepancy, right?
Yeah.
In your first intervention, when we talked about immediate, do we really mean that we have to do it as one stage in that one index procedure, or within that index hospitalization, maybe within a week or so? And then after that, maybe you can call delayed or something. So I think the definition of these terms are very important. And also, if we talked about real immediate, I mean, one stage, all culprit or non-culprit intervention, then the surgeons must take part as well. Like I have mentioned earlier, Dr. Xu had mentioned the CTO lesions or some of the lesion subsets were actually excluded from the trial design. But actually in the clinical practice, those are probably the most determinant lesions that we need to think about. But unfortunately, there's no trial to guide us. I think for easy non-culprit revascularization, I think everybody, all of us will do it. No need for support, easy lesions, maybe 1 or 2 stents extra. I think most of us will just do it intuitively. I think that the issue is where you have a unstable patient hemodynamically, you have diffuse multiple lesion involving left main, for example, and then you have to think about rotablation or other more extensive treatment and a lesion with the CTO. So I think those are subsets that beyond the trial results, and sometimes you just have to make decisions according patient to patient, case by case.
Yes, totally agree with Professor Gao.
Yeah. Well, you mentioned something about MCS, and also very interestingly, that is our topic to be followed. We do still have maybe 2 to 3 minutes. Any more questions or comments? Okay, if not, thank you, Dr. Xu. We will move on to the next talk.
Thank you.
The next talk is given by Dr. Ronnie Shantoff from UAE. He's currently the director of cardiac cath lab and the cardiac wellness, and the consultant interventional cardiologist from the Heart, Vascular, and Thoracic Institute, Cleveland, Abu Dhabi. So his talk today will be benefit of mechanical circulatory support in PCI of acute myocardial infarction with cardiogenic shock. And he will discuss the comparison between the danger shock and the ACLS shock. Okay, please.
Wonderful. Thank you very much. Well, I think we'll add a little bit more confusion to all these wonderful topics. And let's get started. Can you see my screen well?
Yes, yes.
Oh, wonderful. So I have no disclosures, and so I think these are absolutely wonderful topics, and these are really at the crux and at the forefront of what we discuss on a day-to-day basis. And so we'll just add a little bit more to that. So just some background, as we know, in our STEMI patients, cardiogenic shock can complicate those cases in up to around 10% of patients, which is not a small amount. Mortality for these shock patients are anywhere from 40 to 50%, even higher in some of the trials within 30 days. Our shock trial, which really looked at AMI plus cardiogenic shock, showed us that early revascularization with either PCI or CABG, when you compared it to standard of care, showed a reduction in mortality, not at the 30-day mark, but really when we looked beyond the 30-day mark. So at the 6-month mark, the 12-month, and even 6 years out. And this sort of established the concept of early revascularization in our shock patients. Culprit shock, which has been touched upon, really looked at the benefit of, well, asking the question, should we attack only the culprit lesion versus looking at complete revascularization in the setting of an immediate PCI, and just as all the wonderful discussion that has taken place in regards to what's the timing. In this trial, they essentially showed that if you do just a culprit lesion, you saw a reduction in combined endpoints of 30-day death or renal replacement therapy. The primary endpoint was driven by a reduction in mortality, which we see over here. These were sustained out to 1 year. When we looked at the IVP shock trial, which looked at intra-aortic balloon pump in cardiogenic shock, IVP was not associated with lower 30-day mortality, and this really established the concept that maybe upfront balloon pump as a routine strategy for every single patient in shock with AMI may not have clear benefit. And so this actually got downgraded in a lot of the societies, and even in looking at the European Society guidelines, AMI plus shock was downgraded to a class 3B. And so when we look at our recommendations, we see here class 1B in regards to immediate angiography and PCI of the infarct-related artery. When we look at routine use of balloon pump and ACS,
I think the signal is terminated.
Yeah, I think so.
It ceased.
Mm.
Okay. Can someone try to fix that? Jiang 先生, Jiang 先生. Can someone fix that?
Dr. Gao,
Yes.
for your reference, he last time he also has this problem. Suddenly his internet disconnect. So but he will be back in a few minutes, I guess. But I don't know why, because it's happened before.
Wow. Okay.
Yeah, his image seems freeze. I think that's an internet problem in his side.
But sometimes he will not know he is the.
Yeah, someone needs to
So
notify him.
somebody need to notice him.
Ah,
Oh,
well,
I see.
the electricity is off.
The power failure in his side.
Ah, I see.
I see. That's
I see.
terrible.
Wow.
Yeah, I see. Well, in that
Okay.
case, maybe.
Yeah, maybe Israel is doing something. Okay, but I think anyway, most of us should be more or less familiar with the topic, right? It's about IABP shock, ECLS shock, and the danger shock trials, right? Before he resume his connection, can we have some freestyle discussion here?
Yeah, he will be back in 2 minutes.
Okay. Okay. So
Oh, he's reconnecting now.
Okay, good.
Yeah, he's coming.
I think we all know the IABP shock trial, but interestingly, still a lot of people use IABP during their procedure. Maybe mentally that is a comfort or support, mental support. But I mean,
Oh,
okay,
he's come back.
yeah.
All right. Sorry about
Good.
that. One of the joys of being in Lebanon, sorry, the electricity cut randomly. And so we are back online. Okay, I am unsure. Did we go through this slide right here?
Yes, yes.
Okay,
Correct.
wonderful. So really this set the stage. So just to continue on, this set the stage to really ask the larger question about mechanical support, even beyond a balloon pump. And as we know, there are multiple support devices out there, RV support devices, LV support devices. And when we look at the fundamental ones that we're really thinking about are VA ECMO, balloon pump, and Impeller. And we're going to focus the rest of the talk on Impeller and VA ECMO in regards to the two contemporary trials. And so what we saw actually quite interestingly is after the shock trial came out, the IBP shock trial came out, and even shock 2, we saw an increase in VA ECMO and other mechanical support device uses, where this actually was a rise in a factor of greater than 10 in the last 10 years here in Germany. This is a German registry, with sort of minimal impact on mortality when looking at it in regards to in-hospital mortality data. And so, of course, we really lacked high-quality randomized data to support the use of mechanical support devices. And we had one trial that demonstrated improved survival with ECMO when it compared before PCI versus after PCI in patients with refractory shock and STEMI. We had 3 other small randomized trials that showed no benefit to axial flow pump, looking at cardiogenic shock in STEMI patients. We had observational analysis that suggested maybe there's an increased adverse risks when it comes to comparing some of these support devices versus balloon pump, including maybe mortality, bleeding, limb ischemia. However, what did come out of this are really more robust ways to start to categorize patients in regards to shock. And 2 key metrics I think that are really important is one is an establishment of the lactate level used to help determine a patient's risk and to really incorporate that into shock stage staging. And so this really came nice paper in 2022 that really clarifies or categorizes patients in regards to their shock category, and looking at really the different groups, asking the question of where they stand in regards to their blood pressure, where they stand in regards to perfusing the body, and looking at metrics such as lactate levels, ALT, and pH in refractory shock patients, and asking what are the treatment intensities, and using that to start to categorize patients. And this really helped us. This is really, I think, going to help move the data in this space forward. And so just to kind of move here, we saw with no clear mortality benefit when we were comparing balloon pump versus mechanical circulatory devices such as Impeller or tandem heart. On the left and on the right side, we can see a few metrics that may have improved, such as the blood pressure, the mean blood pressure, the lactate levels. But again, nothing robust. When we looked at looking at meta-analysis of ECLS versus balloon pump, we saw some difference suggesting favoring ECLS in pooled data sets, whereas when we compared Impeller versus ECLS, that favorability was not clearly there. And so this really brings us to these 2 large trials. So one is looking at ECMO or ECLS in infarct-related cardiogenic shock. Another one is asking the question about microaxial flow pump or Impeller compared to standard of care in infarct-related shock. So let's go through these 2 trials. So the first one really looked at patients and randomized these patients. So these are patients with cardiogenic shock complicated by AMI, and that could be either STEMI or non-STEMI, plus obligatory. Patients had to have planned revascularization. They had to meet metrics in regards to the hypotension, and they had to show some form of hypoperfusion, and that had to be at least one of the following: either altered mental status, cooling clammy, or not making urine. And fourth, they had to have a lactate above 3, which I think is critical because we start to get objective evidence to help us. And of course, there had to be informed consent. And so these patients were randomized either to standard of care versus ECLS plus PCI. And then we'll look at that in regards to what was the flow. Now, exclusion criteria is patients that were under resuscitation for greater than 45 minutes were excluded, so long resuscitation time. If there was any mechanical cause of cardiogenic shock, if the onset of shock was quite delayed by the time they presented, and if there's severe peripheral vascular disease or they're outside of the age bracket or other couple comorbidities, would keep them out of the trial. And so just some key factors to look at. So these patients clearly showed signs of impaired organ perfusion with altered mental status, oliguria. You can see the percentages here in both groups. STEMI patients, this accounted for about 60 or about two-thirds of patients were STEMI. The rest were, of course, non-STEMI patients. Resuscitation before randomization. These are a large group of patients that actually were cardiac arrest patients. And I think that's an important metric to keep in mind when we look at the trial result data. Median time before a ROSC was about 20 minutes. So this is a reasonable amount of CPR. And our lactate level was quite high, averaging around 6.8 to 6.9 in the trial. When we look at our SKY shock stage, we see that around 50% of the patients were stage C, and really 50% were above in D and E. And specifically, you have almost about 35% of patients were in group E. So that's a large portion of patients in this trial set. Most of the patients received TIMI-3 flow after revascularization, and about 25% of patients, or a little less, got immediate PCI of the non-culprit lesions. And so that's at the same setting. Now, we looked at ECLS therapy. We can actually see there's a couple things. 12% of patients in the non-ECLS arm actually also still did get ECLS therapy. And what was interesting is the majority of patients in the ECLS group got their placement of ECMO that occurred after revascularization. So these are not patients that had upfront mechanical support followed by PCI. Half of this group actually had PCI followed by support. And about 25% in the group that did get ECLS underwent the same thing. Now, when we looked at peripheral antegrade perfusion sheets, majority of the patients did have a perfusion sheet. So in regards to limb ischemia, and LV unloading only occurred in about 6% of patients in the ECLS group. So you had a majority of patients on the standard of care group that actually, not a majority, sorry, 30% of patients had LV unloading with a secondary mechanical support device versus only 6%. Now, of the patients that did not get ECMO, you still had 15% in the non-ECLS group that did get some sort of support device, with the majority being Impeller CP. So you have quite a number of patients that had mechanical support devices in the non-ECLS group. In regards to target temperature management, you can see here about 40 to 50% of patients received target temperature management. So mechanical support devices in total, if you really look at this trial, you had a group that had 92% versus 26% had some form of mechanical support device. The median duration of ventilation was anywhere between, is around 6 days, and catecholamine use was quite common in the group. And so what did we find? We found essentially no difference in the primary outcome, which is death from any cause. So still, again, as historical trials show, around 49% of patients had died when presenting with shock plus AMI. And secondary outcomes, we saw we saw no significant difference in regards to renal replacement therapy, repeat revascularization, or recurrent MI, or rehospitalization for CHF, or neurological outcome. Safety outcomes, we saw an increased signal, an increased likelihood of complication from ischemic vascular complications, warranting some sort of intervention, so almost threefold higher. And moderate severe bleeding, we saw, again, almost 2.5-fold higher risk of moderate or severe bleeding. So there was no clear subgroup signal in regards to the patient group that was analyzed here. And so really to summarize this group, this is immediate routine VA ECMO did not improve clinical outcomes. There are some challenges in regards to the interpretation. We had a high crossover rate to VA ECMO in the standard arm. This was really a heterogeneous cardiogenic shock phenotype. This included a lot of cardiac arrest patients, and the inclusion of the crossover in the combined primary endpoint could have impacted the results. 50% of patients received ECLS after PCI. So of course, this comes at a question of whether or not performing it before PCI would have had any impact. And a high percentage received immediate non-culprit PCI, and what that would need to be teased out, whether or not that affected, of course, some of the downstream findings. Almost a little bit above 8% did not receive ECLS in the ECLS arm. And as we talked about, almost 26% actually had either ECLS or Impeller in the control arm. We had more LV unloading in the control arm, and we talked about the signal there. So I think the trial itself did not, to me, fully answer the question if mechanical support device is able to reduce mortality in the setting of coronary of cardiogenic shock and STEMI. What it did show us is that immediate routine uses in a routine fashion may not make a difference when you look at all comers of cardiogenic shock with AMI. Now let's move to the danger shock trial, which in principle asks a similar question, but in design, it really, I think, focuses slightly on a different question here. So these are patients that when they presented to the hospital in shock and it was diagnosed, they were evaluated for the efficacy of Impeller CP specifically in treating these patients. These patients had to have a STEMI. They had to be within less than 36 hours of presentation. Their lactate had to be greater than 2.5. Their EF had to be low, and they had to meet criteria of having a low blood pressure or be on inotropes. And then they were randomized to the two arm groups. This took a long time to enroll patients. It took almost about 10 years. And of course, this can come up in regards to why this is the case. Of the patients assessed, you had a large number of patients excluded, and you're left with randomization of about 360 patients. The primary outcome measure was all-cause mortality at 180 days, and the secondary outcome measure was looking at the combined endpoint of need for additional mechanical support, heart transplantation, or death, whichever came first. And a secondary outcome was days alive and out of the hospital. We're looking at the time frame of 180 days. Exclusion criteria, so the shock could not, just to highlight certain ones, shock could not be greater than 24 hours. They could not have another cause of shock. An out-of-hospital arrest with persistently low Glasgow Coma Scale score was excluded from the trial, even irrespective if they had spontaneous recirculation, circulation. And I think that's an important point. This is not really looking at cardiac arrest patients or persistent arrest patients. This is looking at shock patients with STEMI. And they could not have severe right ventricular failure. So this is a very narrow group of patients and a tight sort of definition. Their arterial lactate levels were slightly lower when compared to the other trial. They're averaging around 4.5 to 4.6. EF, of course, is low. And resuscitation before randomization occurred in about 30 to 40%, in about 20% of patients. Now, when we looked at their SCAI shock category, again, you see the majority of the patients here were in category C and D, with a lower percentage of patients in category E. 72% had an LAD or left main culprit, and as expected, 72% had multivessel CAD, so the majority. And so, again, just categorizing these patients. The approach, the trial was patients were randomized, placed on an Impeller support, yes or no, and then monitored for the 2 days. And if there was any signs of unstable hemodynamics, they were considered to move to more full support, which could include LVAD or ECMO. Or if as they're stabilizing, then you started the weaning protocol of Impeller based on the recommendations from the trial design. What did we find? So in terms of management, non-culprit PCI was done in approximately 44% of patients. Placement of Impeller CP occurred, you have a drastic difference. So you have a clear 95% received Impeller support device versus only less than 2% in the standard care group. So I think you had a clear division in regards to who got what. Majority of patients were randomized before PCI, and the flow pump was placed before PCI. So these are patients essentially that received support followed by intervention. in terms of additional mechanical support device, what we can see here, if you look overall, VA ECMO was placed in approximately 20% of patients, 18.8, so 19% of patients in the standard care group versus 12% in the microaxial flow pump group. So looking at in totality, any escalation to any additional mechanical support was 16% versus 21% in the two groups. And again, as expected, a lot of vasopressor support usage in the trial. When looking at hospitalization, we saw a larger percent of patients who were still hospitalized at day 30, with 23% versus 11% in the standard care group. Staged PCI was 4% in the microaxial flow pump group versus the standard of care was at 6%. So the majority of these patients received immediate revascularization. We don't have more details in regards to the exact timeline, but this is how it was defined. What did we find? We saw a reduction in death from any cause at 180 days, which was the primary endpoint. So it's a reduction from 58.5% to 45.8%. And so it's a significant reduction. Our composite cardiac endpoint also was statistically significant with a reduction from 64% to 53%. And again, that was a combination of additional mechanical support device, heart transplantation, or death. When we looked at adverse events, we clearly saw an increased risk of adverse events. So when we looked at the composite safety endpoint, we saw almost a 4.7-fold increase in a safety event signal. When this includes moderate or severe bleeding, limb ischemia, and renal replacement therapy, which was increased. Sepsis was also higher in the group, nearly 2.8 increase fold. What we did not see is an increase in stroke or cardioversion after VT or VFib. And so overall, we had an absolute 12.7% reduction in mortality with a number needed to treat of 8. And in summary, you have immediate microaxial flow pump in patients with specifically cardiogenic shock, and STEMI did reduce the risk of death out at 180 days. It also reduced the combined endpoint of risk of mechanical support escalation, transplantation, or death. It did come at an expense of elevated complications, including elevated use of renal replacement therapy, bleeding, limb ischemia, and sepsis. There was no stroke signal, and we did have an unexpected renal replacement therapy increase signal, which does question, is this due to more patients that died early in the standard of care group? And so was this a survival bias? Was this due to mechanical hemolysis? Was this due to the approach of a complete revascularization that occurred? It seems to be immediate, maybe with the use of more contrast. So I think these things need to be teased out. In my opinion, this is a targeted trial of STEMI and cardiogenic shock patients. It really focuses on this group. It really excludes our comatose patients. And there was really no significant crossover. So I think we do have to be careful about broadly applying this to other groups, such as shock patients who remain comatose after arrest, MI patients without STEMI, and stage C shock without elevation arterial lactate levels. So patients that really didn't show lactate levels increase, and patients with more prominent biventricular failure. And so in summary, if we were to put the two side by side, some key points, I think routine ECLS had no change in mortality at an expense of elevated complications. This really was a broader patient population group. It argues against routine upfront use of ECMO for all CS and AMI patients, and really potentially should be reserved for select use. I think in the end, we still have to have a shock team approach when adding mechanical support devices. We need to consider the complication risk in regards to which patient we choose to place ECMO versus not. Some good signals. There was no stroke signal in the trial, which we did see. Looking at our microaxial flow pump group, this did show reduced mortality and elevated at an expense of an elevated complication risk, and really was a focused patient population group, and argues for tailored use of upfront microaxial flow pump in STEMI shock patients with advanced class C, D, or E shock. I think it's important that we do need to document arterial lactate levels and consider a mechanical support device pre-PCI as per the way the trial was designed. And this may not apply to patients, of course, with persistent comatose post-arrest patients. And it's still, in the end, we got to consider the complication risk and whether our particular patient in front of us is appropriate for such support devices. again, what was comforting was that there was no clear stroke signal in the trial. And with that, I think we'll end here. Sorry, just to rush it a little bit, just because we lost a little time.
Okay, thank you, Shantov, for a very wonderful summary of all these important trials. So I think the topic is now open for any discussions or comments or questions.
May I? Dr. Shantov, I have several questions for you. And one is how about the microaxial flow pump? How many percentage is the device implant before the PCI? So this is the first question. The second question is the non-culprit PCI is higher than in the danger shock. So do you think if we perform the MCS support, we perform the complete revascularization, then the result will be different from the culprit shock trial? Third question is do you have any data about the cardiac power output during these trials? Did they mention that the CPO increased to what level?
Great. I think these are great questions. In regards to a placement of the microaxial flow pump before PCI, this occurred in nearly 85% of patients in the flow pump arm, and occurred in 100% of patients, which was 3 patients in the standard of care arm that did still receive Impeller treatment. So majority of these patients had mechanical support that was prior to PCI. In regards to complete revascularization, I think that's a good question. Some of our data shows that in the setting of shock, we actually should not be performing complete revascularization. So whether or not that hurt or helped, I think it's going to be hard to tell unless the trialists really start to look in, or somebody dives into the data a little further. There was not much in regards to the primary trial or subsequent papers that I was able to find. Cardiac power output, there was zero mention of it at all in the primary papers. And so I think that will also be important to look at in regards to how this was managed. The patients were managed to actually were placed on full support at the very beginning. And so there was one question about whether or not keeping them at full support, maybe that was not necessary for the course of the subsequent days, and whether or not that did contribute to hemolysis or not, and maybe it impacted the outcome in regards to renal replacement therapy. So I think, these are 2 great trials, and seeing a little bit so folks can start to sort of tease out the data and the trials will start to create more questions, and of course help for trial design for future papers.
Yes, great trials. I agree. Thank you.
Yeah, I think this also touch upon the concept of door to unloading. So I think in the current era of primary intervention, we are so focused on door to balloon time, but actually before we reperfuse the ventricle, maybe some time spent on unloading the left ventricle is worthwhile. And I think there are trials still ongoing. So maybe in the near future, we will have the answer for that. But I think if you want to use a microaxial, you have to use it up front. I mean, don't just use it as a bailout when the patient crash and then you hastily go into the establishment of the MCS. That will obviously enhance and increase your complication rate, and also maybe it will be too late.
I think that's a great point. In the end, we all have to take the data and practice the clinical medicine in front of us. And so if the patient really looks like they are not going to be able to tolerate going through the PCI, then unloading them up front, makes the most sense. I agree completely.
And I also have to emphasize that in the danger shock, you have a 180-day survival benefit, and the number need to treat is just 8. I think these are all very, very strong and significant message that we should be giving out.
Yeah, I do wonder, because in the ECLS trial, majority of the patients, or nearly 50% of the patients, received ECMO after revascularization, and whether or not that would have made a difference in the trial. Maybe that would be worth a subgroup evaluation if they can really tease out the patients that received it before versus after. I did not see that data point.
Agree. But well, if you think about or you agree the notion of unloading, ECMO is actually not unloading the left ventricle, right? ECMO is keeping the patient and the rest of the organs alive, but harming the left ventricle at the same time. So I think intuitively, probably ECMO is not the way to go, especially in a MICS situation.
And all you're going to do is increase to the LV. So, which is another issue, is that essentially the majority of the patients were not unloaded afterwards. So they actually just stayed on ECMO. And so I think I agree.
Yeah.
And recently, we have one case that we performed the LA VA ECMO, LAVA ECMO to primary before the PCI. We can see the increased coronary flow after the LAVA ECMO before the primary PCI. However, this patient got improved the LV function. However, because he's the case of the out of hospital cardiac arrest, so he's still dead because of the brain death. So if we collect more high risk or extreme risk patient, then the outcome may be the mortality is difficult to be improved. However, we can improve the LV recovery.
So I think it's time for Dr. Minami to wrap up the webinar today.
Okay. So thank you very much for all for joining us today for this insight through presentations and the discussions regarding the continued progress in medical and interventional strategies for managing myocardial infarction. So today we could discuss 6 very important cutting-edge topics, and we could share the very active opinions from the panelists. So your engagement and dedication to advancing cardiovascular care truly inspiring. As we conclude, let's carry forward the knowledge shared and continue to innovate and collaborate for better patient outcomes. So we look forward to your participation in future events hosted by the APSC. So have a good day and stay safe. So thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Thank you.